The first talk is by Dr. VISHALI GUPTA. She's going to start the whole session with her topic on tips and tricks RD in retinochoroidal colobomas, and then we'll go on from there.
Thank you. Thank you very much, Manish. And as already mentioned by Manish, it's really a pleasure to see friends again and not staring into the screen and speaking. So the topic that I shall be talking about are the tips and tricks for doing RD surgery in coloboma. Now, before you actually take up a coloboma patient for surgery, this is the kind of the classification which you should know, and it generally tells you whether it is involving the optic nerve, whether optic nerve is abnormal associated, so it's good to know about it. Now, this is the only retinal surgery where I feel it's not about just do it. It's more about you have to know the applied anatomy and the structures and what you are doing and why you are doing that, So for this, applied anatomy for retinochoroidal coloboma plays an important role. Just a few things. I'm not going to bore you with anatomy, but it's just there is an incomplete closure of embryonic fissure. So what does that cause? That causes a split in the neurosensory retina. RP is redundant. Neurosensory retina gets split into two. And those two layers are the inner neuroblastic layer, which is commonly called intercalary membrane. And that is just a very abnormally thin retina. And the other one is the outer layer, which is neuroblastic layer, which is fused with the RPE. So now you have a coloboma patient sitting in front of you. What are the concerns? The first thing is try to find out the break preoperatively. And since the intercalary membrane is very thin, it's just atrophic. There is no contrast. The breaks that are located in the intercalary membrane are not going to be easy to identify. So you will have to spend some time there. So look at the coloboma margin. The retinal layer will continue from there onwards as intercalary membrane. And the zone of the adhesion is the point of least resistance, and that is why you will hear the term local minoris resistant. So this membrane is very taut, and I'm going to show you in video how taut ICM can be, which causes traction on the retina. And this transition zone is very important because the breaks may be located somewhere here. So how do you go about it? First thing, there are three possibilities. One, there is a coloboma which is just sitting there quietly, not contributing to RD, and you have a usual RD due to a peripheral break. Now, if that is the scenario, just ignore the coloboma and manage it as you would have managed that detachment without coloboma. The second scenario is this is the area where this is the local minoris resistance. That's the margin between the coloboma and retina. And this is the area where you will have to find the breaks. And believe me, it's not easy to locate these breaks preoperatively. So only thing you can say is, well, the peripheral break is not there. The RD is probably due to coloboma. You may be able to find the breaks within the intercalary membrane, which are relatively easier to find, and they may be staring at your face sometimes. So if you have these two, then this detachment is related to coloboma. And very rarely you may have both the things. There are breaks in the coloboma and breaks outside. Now, as I mentioned, the tip number one was the identification of the break, which could be in the periphery, which could be in the LMR, or which could be within the intercalary membrane. Now, besides your clinical judgment, what instrumentation can you use? Well, you can use OCT, but you have to have a patience bringing the OCT to a point where you are suspecting break. And if you are fortunate, you may be able to find this break and locate it either in the intercalary membrane or at the locus minoris. But for that, you need a lot of patience and getting the OCT scan passing through that particular line. The second is before you actually begin surgery, and this is the surgery done by one of my fellows, Atul. So before doing the surgery, if you are suspecting a break somewhere, you pay attention. Now he was suspecting the break to be this. So you can actually zoom your microscope, and you, if like we have MIOCT, you can use it, but even if you don't have, it's okay. So you can zoom and you may be able to see a slit or a hole in the intercalary membrane, which you are able to identify before you actually start doing surgery. Now you have started the surgery. So what are the tips? In cerclage, there is no definitive advantage, but if you have a peripheral break which you want to cover, sure enough, but otherwise there are no do's and don'ts about putting the cerclage. PVD induction can be tricky, so you got to be firm, but you have to be gentle, because I'm going to show you in next video that retina in these, I don't say children, but in these patients tends to be very mobile. So when you are doing very forceful PVD induction, you may have the retina coming into your port. And also many times the vitreous may be in layers. Again, I'm going to show you in the video that you have to look for the schisis. Very importantly, I will talk about fluid gaze and laser edges later. Now the first thing about anatomy which I said is that you have coloboma hair, you have intercalary membrane, and you have a break in the intercalary membrane. Now what is happening is that you have the hyaloid which is attached at locus minoris, and a part of hyaloid is also going over the coloboma. Now that hyaloid is something which is very difficult to differentiate from the rudimentary retina, because when you are on top of the coloboma, everything appears the same. So for that, when you are putting the, he's trying, you can see, putting the triamcinolone, you take out the triamcinolone as much as this, and whatever the residual triamcinolone, as you will see here from the video, that after removing the triamcinolone very nicely, both over the coloboma as well as at the margin of the coloboma, then you try to find where possibly the edge of that hyaloid could be, which is extending. Because if you put your forceps here directly trying to pull it, you may pull off the intercalary membranes along with it. So that might become an issue. You don't want to do that. That's not your aim of the surgery. So what you do here, from the edge, you can see from the edge the hyaloid can be identified. Go along the hyaloid, and this part of the hyaloid which is over the coloboma, that has to be taken off. Only then this rigidness or traction would go away. And then this is the video I would like to show you about mobility of the retina. Now you can see we have done core vitrectomy. We have injected triamcinolone. You see, this is the mobile retina which tends to jump into your cutter. So you have to be very sure as to when you are removing the vitreous, you are doing it, the word is firm but gentle. So don't go on a very high suction, and don't go too, aggressive about it. Inject triamcinolone second time, even if you think you have removed it, because the vitreous can be very adherent and it can be in multiple layers. So even if you have removed the first time vitreous, you can see here, there is another layer of the vitreous which was not coming with the cutter. So you may have to use forceps or anything to separate this second layer of the vitreous, which again you will use your cutter to nicely shave it off from the surface of the retina. So you can see, go close, remove it, make sure there is nothing, because this is the problem in these children. The fourth tip which I was telling you was the fluid gas exchange. When you are doing fluid gas exchange, you will have the ballooning of the retina, because you may not be able to identify small breaks in the local minoris. I will just take one more minute. And you can see here, this is where the break was, and when you apply your suction here, the fluid starts draining out, and of course you can later on drain it through the intercalary membrane also. If it's not draining, there is fine to make a retinotomy and drain through it, but by and large you'll be able to drain through the primary small breaks. Laser is important, and there is, they say you laser the entire edge even if it's involving the foveal edge. To be very honest with you, I have never had a heart to treat the fovea even if the coloboma was at the edge. So I reserve it for the second surgery if these patients require. And this is, you can see, this is the patient pre-operative. You can see this detached retina, and this is post-op. You can see I haven't lasered it here. I just don't feel like killing the fovea. So to conclude, the knowledge of the surgical anatomy is important for retinocoloboma surgery. So only difference I see between this surgery is actually simpler than many other complex diabetic surgeries and all. But only thing which I feel and I teach my fellows is they have to know the anatomy. They have to know what they are doing, what they are cutting, unlike rest of the retina where it's just do it. Thank you very much.
Thank you, Dr. Vishali. So I will invite our next speaker, Dr. Manish Napkal. He will talk on the management of large submacular hemorrhage. Yes.
I would not use PFC. Yeah, I would not. So that's why you have to spend a lot of time in, because there is coloboma, then there is taut intercalary membrane, then there are maybe large breaks in the intercalary membrane. So if PFCL goes behind this, then you create a mess. So by and large, you generally do not need,
So I request Dr. Vaishali to come and take this chair here. So meanwhile, may I ask you some question, ma'am?
Yeah, sure.
Yes. Like if the break is somewhere within the macula and the macula is partially involved in the coloboma, will you do the laser in the macular area or close to the fovea?
Yeah, if I see the fovea is knocked off, I'll do the laser. I will just go very gentle laser burns there. But if it is really involving the fovea and the fovea is already gone, I will do it. But if I see that yellow pigment and fovea, I just go juxtafoveal. I know it should be done through the fovea. It's just, I don't feel like doing it.
And what is the power setting?
Power setting is about, mine would be very low, say about 100 to 150 micron.
Okay.
A bit larger burn and a very, very mild gray burn closer to.
Okay. My second question is, are you routinely using PFCL if the break is at the periphery, not at the posterior pole?
For colobomas, I prefer not to use PFCL.
Okay.
So thanks. If I can ask one, very nice presentation with excellent resolution. It's a difficult surgery. And I don't know if here in the audience, how many here are going to do these kind of surgeries in the future. But one question which may be relevant for them is a coloboma with no retinal detachment. What would be the indications for laser, and when would you do those cases for prophylactic laser?
Raja, again, we do not have level 1 evidence to say whether to laser or not. More LVP group like Subhadra has published doing the laser to the coloboma without detachment all across helps in reducing the recurrences, but there are other published reports also which say that laser of the coloboma does not really make a difference. So for me, it would be doing a good peripheral examination to see there is nothing else going on. The second step would be, is there a RD over the coloboma? Because many a times we may have a localized RD involving the coloboma.
Intercalary detachment.
So
Yeah,
you're
intercalary.
asking of prophylaxis or during surgery?
No, he's asking
prophylaxis.
prophylaxis.
So personally, even,
I don't
as a
do.
comment, I never do it.
I never do
because
it.
As Vishali said,
I don't
we
do
have a soft corner for the fovea and macula.
Yeah.
And if you're going to leave that much area barren,
Then it doesn't make a
actually
difference.
doesn't have much, and there's no evidence to show that it has reduced. So,
Yes.
So I think many people probably have lasers. They
Yes.
might be willing to do laser
Should
as a
not be done.
prophylactic laser barrage. But
yeah.
some of my considerations include if the ICM is already lifted, there is going to be a break which may or may not be. So if you have an ICM break, intercalary membrane break, or a detachment of the ICM, I would go. And if the other if patient is one-eyed, I don't know when.
That is what I was going to say, that you look within the coloboma. If there is a detachment, then you may consider, but otherwise if coloboma is nice and flat, I will not.
But the ICM detachment is not easy to pick up in initial stages. You need to learn it slowly with experience. But
you
thank
can
you
use
so much.
OCT.
Yeah.
OCT works very well for ILM.
Absolutely. But thank you so much, Dr. Vishali.